And we are broadcasting from the World Health Organization Western Pacific Regional Office in Manila, Philippines. Before we start our session, let's have a quick orientation on how we can make the most of our participation today. Please focus on the screen of our WebEx right now so that you will be guided for our presentation for our meeting today. Some things to remember: we're now using Cisco WebEx Meeting Center, and if you encounter problems, please leave our meeting room and rejoin immediately. Your mic will be muted for the rest of the meeting, and for questions, you can use the chat box in the lower right panel of your screen. And you could also raise your question via voice by clicking the Raise Your Hand button on your chat panel. Chat your name and designation for your introductions in this meeting. So kindly chat your name and your designation or affiliation for this meeting. I see on our chat box that some have already made their introduction. So for this time, I'm going to make my introductions. I am Aliyah from AeHIN Information Network. So you could do your chat. Please chat to everyone, not only to the Secretariat. So we also have in our meeting room Winmit, who is from the Thai Health Information Standards Development Center, working also as the Satellite Secretariat in Thailand. Thank you so much. We also have Mohammed from Bangladesh, and we also have friends from Nepal, John. Yes. There. Thank you so much for the introductions. Keep it coming. Do not send privately. Please send to everyone. We have here Indrajit, Additional Director for the National Health Portal of India. Thank you so much. And also, please stand by for the photo taking session at the end of this meeting so that we could document our virtual presence for this AeHIN Hour. Thank you so much. If you have, we will all be muted for the rest of our meeting to accommodate and to facilitate better discussion and knowledge sharing. Thank you so much. So before we start our session, I would like to introduce to you our speaker. Our speaker is Rahul Mullik, who is the Technology Leader for the India Country Office of the Bill and Melinda Gates Foundation. He extensively focuses on enabling mHealth and eHealth solutions across the programs of the Foundation in India. He comes from a technology consulting background with an extensive e-governance experience. He was previously a partner with PwC, leading their e-governance practice. Prior to that, he set up the e-governance practice for KPMG and was a director in the management consulting practice. He brings 17 years of consulting experience across Big Four consultants, PwC, KPMG, and Ernst & Young, and large IT companies like Wipro. He has also worked extensively in Asia Pacific and headed Wipro consulting business in the region, based out of Melbourne in Australia. Please welcome Rahul. But before we give the floor to Rahul, I would like to welcome Tim Wood for a very short introduction about this session. Tim Wood, welcome to the meeting.
Thank you, Leah. Everyone, I'm a senior program officer at the Gates Foundation and have been working in the mobile health arena for over 5 or 6 years now. The Gates Foundation started off with mobile health projects in sub-Saharan Africa, and we very quickly realized that there was a pressing need for a versatile set of software tools that could be applied to a wide range of mobile health scenarios. We endeavored to create an open source software system that could be used that would build upon standards that were being developed in the international community. And after some initial deployments in sub-Saharan Africa, our largest deployments happened in the Indian state of Bihar, where we work with 3 different Gates Foundation grantees who deployed services across a range of scenarios, from tuberculosis control all the way through maternal and child health services to community health worker training. And my colleague Rahul from the India Country Office is here to tell you a little bit more about those implementations that have happened in India in a bit more detail. And we also have John Tippett from the Grameen Foundation on the line, which is one of the organizations that is driving the creation, adoption, and development of the MOTECH system. So with that, I'll hand it over to Rahul.
Thank you so much, John. Team, I'm sorry, Rahul, you are now on. Hello, Rahul.
Hi, can you hear me, Alia?
Yes, very well, thank you.
Right, thanks very much for your introduction, Alia, and thanks very much to Tim for giving that quick introduction. I just thought I will set the agenda for this presentation before I get into it. Alia, I'm presuming I have the control of this slide and I can move it.
Yes, you can move it now.
All right, let's move to slide number 2. So the broad focus of this presentation is to give you a view of how do we in the foundation, along with our partners, see the vision chain rather, which is in terms of how do we see outcomes across the value chain of healthcare, and therein where do we see the specific interventions of technology. So I would like to share that a little bit with you, and more with a on-ground example from India, and try and contextualize it and to your respective countries and where you see similar activities. Based on that, I would also talk to you a bit about what are the various mHealth interventions which are possible on the ground, and the theory of change which we have adopted to try and make those interventions using technology. We'll get into the details of the MOTECH platform, which serves as a great enabler for some of these interventions and to validate those theory of change which we have put together. And specifically, I will talk a bit about MOTECH in the Bihar program and the overall ecosystem. I will also briefly touch upon the MOTECH timelines and learning, and there I would also bring in inputs from Tim, as he has been among the pioneers of putting this platform together even in his earlier role with the Grameen Foundation. So that's broadly the agenda. I expect to take about 30 to 35 minutes. We can have Q&A, whichever way you prefer it, either towards the end, or if you feel that that's something we can do during the presentation, I'm okay with that as well. So broadly, not more than 13 to 14 slides, and keeping it to around 30 to 35 minutes. Moving on to slide number 3. Essentially, we looked at the entire vision chain across 5 key parameters. One was behavior change and increasing demand. How do you ensure that actual healthcare behavior on the ground changes, because that really impacts the health outcomes. Managing the data associated with it. So the recipient of the healthcare, how do we manage the data which is of that recipient to make sure that we have an end-to-end view of their history and clinical record. Improving the worker performance. When we say workers, we mean frontline workers or community health workers, as they are called in some countries, who are people who actually work with the beneficiaries on the ground. The supply chain issue, how do we make sure that to provide healthcare, whatever we need is available right up to the recipient of that particular requirement. And finally, and if not more importantly than anything else, all this will not work if you don't have patient adherence. So you can have the best treatment, you can have behavior change indicators, you can have registration record, you can improve the worker performance, but if the patients don't adhere to certain health treatment and plans, how do you make sure that the actual health treatment gets delivered? So we looked at, that's for us is the vision chain, that how do we across this chain enable capabilities within the system, both from a technology perspective and from various other interventions. Technology is just part of those interventions. And what are the benefits we accrue? So to give you an example, and the slide can be read subsequently as well, if you look at what are the behavior change and increasing demand capabilities which we require, from a technology perspective, we're looking at building IVR capability. How do we ensure messaging is there, educational videos and job aids which will be there for the people, and how do you ensure that some pull-based technology is available, so in case people want to look at or view or get a help on technology on healthcare, they have pay-as-you-go subscription-based options available with them. We believe that some of these capabilities will necessarily bring in far greater benefits to them. We will be able to reach out to those patients far quicker and leverage the mobile usage is there extensively in India, and I'm sure in many of the countries you represent today, there's extensive mobile coverage. And these kind of benefits will actually enable us to ensure that the healthcare service levels actually improve as we go along across the value chain. So there are very clear capabilities which we felt could be built across the vision chain, as we call it, which each have very relevant benefits associated, and these could be across multiple examples which can be cited. This is still a very generic slide. I'll come to some more specifics on this as I go along. Moving on to slide number 4. So when we devised our mHealth theory of change, and some of it was based on what I just mentioned in terms of how we saw the vision, we looked at what are the various foundation activities which are going to support that vision. So whether it is developing the operating plan, refining what our requirements are, enabling the program management, putting the budgets, decisions associated, training, and so on and so forth. So these were the foundations activities which was originally envisaged. Okay, I believe that I will not be able to see animations on this. Is that so, Alia?
So yes, but do you have your slide deck with you, or I can show my desktop if you would like to?
Slide deck, but the others will not be able to see the animation. Anyway, so okay, maybe I'll move on to the next slide because this is probably the only slide which actually had animations, and probably some of it I will cover in the next slide.
Okay.
I'll just move on to the next slide. Okay. In this slide, just slide number 5, I have explained at a very high level what is the overall process, and I've just taken one example, which is the maternal and child health process which works in India. So I've tagged a number to the process so that it's easy for reference as we speak. In our meeting in Delhi earlier this month, I was obviously using a different medium to depict this. In India, we have the frontline workers, which are called ASHAs, which is an accredited health activist in India. She's the one who actually works on the ground with the end beneficiaries. And I think, as Alvin is saying, you have something like this even in the Philippines. The ASHAs actually are people who have limited education, and in some cases very low education. And they are at the village level, and they interact with the various expecting mothers in that village and ensure that they are being given the right kind of health guidance. The ASHA, so that's the ASHA interaction with the beneficiary. The beneficiary is, in this example, the expecting mother, the process 1 which I have explained here. The ASHA in turn works with somebody called an ANM, which you see in the item mark number 2. ANMs are like supervisors of ASHAs, so ANM would have more than one ASHA under them, and they would cover more than one village, and they are the auxiliary nurse midwives. They are actual government employees, and they are the ones who are supposed to keep an overall view of the healthcare environment in that particular area, and they have multiple ASHAs working under them. So the ANMs also interact with the beneficiary because they are experienced and they understand various issues related to neonatal health, mother's health, nutrition, and so on and so forth. So they are the other chain of this particular process, and their interface with the beneficiary is listed as number 3 here. Now, then comes in the picture the primary health center, which is the facility which is available where the beneficiary would be taken for any investigations or other matters, and of course when the beneficiary is ready for her delivery of her child, she would be taken there for an institutional delivery. There's a medical officer there in that primary health center who interfaces with the beneficiary. The medical officer ensures that the beneficiary records are captured and maintained, and there's a government system which feeds in to whom this record is fed in. if there is advice which is given to the beneficiary can go to a district hospital, which you see in number 6B there, and they can get some treatment which requires them to be at a better facility than the primary health center. In turn, the government system captures these records, and the ASHAs are actually paid an incentive for the work they do. So they have incentives associated with deliveries, they have incentives associated with reporting maternal deaths or newborn deaths, and incentives related to immunization and so on and so forth. And the government system would then process that and ensure that there is a payment approval. The payment approval through point number 8 would then come to the primary health center, who in turn would pay the ASHA as and when the funds are available. Now, this is a very brief overview of the system. Now, this system has a few challenges, to say the least. If you notice, there is a register-like icon which is next to the ASHA. So typically, the ASHAs are supposed to maintain all the records on paper-based registers, and these registers are also maintained by the ANM. So ANMs register in a way the compilation of the various registers of the ASHA. The data from the ANM register is supposed to be at the primary health center register as well, which you see in point number 5. So there is a manual record which is maintained from the ASHA to an ANM to a primary health center. At the health center, there are facilities available. As you see, there is an icon of a system and a database, which represents that there is a mother and child system which is available at a desktop in the primary health center, where this information is supposed to go, and subsequently this information goes into a back-end larger government database. The challenges which are there in this system are that the data capture, which happens at the first entry point level from the ASHA, by the time it reaches the primary health center, there is a significant time lag. And before it is entered into the mother and child tracking system, it undergoes a fair bit of manual process. And as a result of that, there are elements of the data being either not appropriately entered, or in many instances, the records are not fully entered and they're not very comprehensive. So essentially, you have records which are not most comprehensive, and in many cases they're delayed. And as you know, that if you are entering records at a delay of 3 to 4 months, essentially you missed out on a cycle of pregnancy, because in 9 months the mother has to deliver. So essentially, if you're delayed by 3 months, I mean, that really doesn't add much value in terms of tracking her well-being and therefore the well-being of the expecting child. So there are some key issues here which are there, which from a data capture and embedding into the government system. So where we have seen, and I'm just going to start with the first instance, where we have seen that mHealth can actually play a major role, is that we felt that ideally the data should be captured at source. And the source, of course, is the beneficiary. So we have enabled a project in Bihar, and I'll talk a little more about it as I go along, where the ASHAs and the ANMs have been given handheld mobile phones with an application on them, which allows them to sort of capture the data then and there. And then this data doesn't necessarily have to go through this cycle of process 1 to 2 to 3 to 4. The data can actually go straight from that handheld device to the government system, and a version of it is available at the primary health center. So it's instantaneous data capture to start with. It is more comprehensive data because the application is designed in such a way that you are able to capture data at regular frequency. The application allows the ASHAs to have a tracking system, a system wherein they can have their plans for them to see every day which beneficiary, which mother they are expected to visit, what are the kind of shots to be given. These are all enabled through a mobile phone. Now, this is a smaller pilot. It's right now smaller by India standards, if I may say so. It's in 4 blocks of Bihar. It covers about 500 frontline workers, and it covers a population of about 1.3 million people. So by that standard, it's reasonably small for us. But that's a key intervention to solve, or at least to have a way around the earlier problem which I mentioned, which is to ensure data integrity. Now, within this framework which I've shown here, there are many other points of mHealth interventions which we are looking at and working. For example, one of the key reasons of maternal deaths in rural India is because we are unable to effectively monitor and track two key parameters. One is blood pressure, and the other one is hemoglobin, which leads to anemia. And we are looking at how we can have technology play a role in the devices which can be used for ensuring that you can have these kind of tests which can be done remotely, where an ANM can carry a device which can measure the BP more frequently, have a view on the hemoglobin count of the mother more frequently. Because presently, the way it happens, the way the process is designed, once a month there is a village health and nutrition day wherein the mother comes, and if at all you convince her to come all the way from a village because it may not necessarily be too close, where she comes and gives her BP and gets her test done. But that's once a month, and provided she comes. But if we are able to make the diagnostic, which is what I'm driving at, also mobile here, then we would have ways to reach the mother wherever she is with that device. And that device can again feed into the data back into the same system which we have overall designed for data capture. So that's another opportunity where we see mHealth, eHealth scope to come in. The other place where we see significant use of this, which is in the point 6D on this slide, is where we have a better view of the supply chain and tracking the essential commodities. Because many a times what happens is that the commodities and essential commodities which are required at the primary health center are not available, whether they are medicines, their devices, their equipment, and so on and so forth. So that's a key area which I am working on with our supply chain team, where we believe that if we can get better view of what the status of these devices, equipments are, then we will ensure that there are lesser stockouts and these are available. Because there's no point bringing in technology in the earlier pieces but not have this problem solved, because this is critical to providing that healthcare service. And the other area beyond this, as I go along this chain, is when it comes to payments of the ASHAs. We must understand that while ANMs get the government salary, the ASHAs work only on incentives. And incentives have to be paid only based on actual eligibility. And eligibility can only be tracked if you have some form of records to track them. And given that we have such delay in these records being captured and so on and so forth, many a times this money, which is not very, very significant, and I'm actually talking money which can be as less as $20 a month. But still, that's very important for the ASHA because, for her to be motivated to work or even allow her family to allow her to do this job, they need to see some flow of money. And the present process is, of course, quite cumbersome. It can take up to 6 to 7 months for them to get even that incentive through the government systems. So we are working on a system already in Bihar. The pilot is already on, where we have the payments which are directly credited into the ASHA's bank account. And that, of course, also presumes that many of the other IT systems would be in place. You would have the record of the beneficiary, and ASHA would be tagged to that. All the services which the ASHA will provide to the beneficiary would be available. And based on the services provided, an incentive calculation would be worked out. And through the government payment systems and onto the bank account of the ASHA, that payment would be made. So there are at least 3 or 4 areas. I've highlighted 4 areas. There are many more which we would think as we go along, where we believe that the mHealth interventions are going to make a significant difference in the way this process works and works more efficiently. Let me move on to the next slide. It's slide number 6. This is where I talk a bit about the MOTECH platform and the need which drove us to have a cross-sector M services platform like MOTECH. MOTECH is an example of an open source M services platform. We have enabled it to provide for it to be an integrated suite for all M-enabled modules, and it works with many of our grantees and partners and allows them to build and deploy mobile-based applications. So that's the core behind MOTECH. It's presently deployed a lot in the healthcare sector, but it's sector agnostic, and we expect to see MOTECH being used in many other sectors, and including agriculture, which is another big focus area for the foundation. Why do we feel that we need to use it? Because for all the reasons which I mentioned and what MOTECH allows us to do, it actually allows us to measure the beneficiary behavior and track it across multiple sectors. So the applications are designed in such a way that we have a very efficient way of analyzing the information, and not just from a compliance perspective, but also from a behavior change perspective. Obviously, the platform allows us to have greater accountability because the data is getting captured across various applications, and we are cognizant of the fact that as the platform grows and its usage grows, we would standardize and work towards having common data stores within the same program, and that will be of immense benefit because from a common data store, we could have the same data being used for beneficiary tracking. We could have the same data for diagnostics analysis. We could have the same data, which also has data of the primary health center and the facilities for supply chain, and since we have the data of the frontline workers, that will be used effectively for payments. So we have provision in the MOTECH solution to have the respective data stores integrated so that we are able to do far better data management as we go along. This, of course, gives us the benefit of having significantly optimized costs because the platform can be used across multiple areas, and you drive a fair bit of economies of scale as you do that. More importantly, and if not most importantly, having a platform like this actually helps us accelerate our process of innovation. As and when we come up with a solution or an area where we believe the solution can be implemented, we are able to see how MOTECH can add value to that and therefore integrate that. So our partners who work very effectively with us, partners like Grameen, partners like Dimagi, and our various on-the-ground partners, understand this, and we are able to together jointly drive some of this innovation. Moving on to the next slide, slide number 7. Okay, again, this slide also had an animation, so there was a table at the back before the front table could come up. But just to give you an idea, the table at the back, and you can probably view part of it, was actually talking about all the health indicators which are there in India and for the state of Bihar, which we used as a baseline when we started working with Bihar back in 2010. That how do we want to move from those indicators and improve them significantly? Since one of them is visible, I will talk about that. The MMR, which was at around 260 or so at that point in time, about 3 or 4 years ago, we've set a goal that in the next 5 to 6 years of our starting the work, we would try and bring it down to a level of 175. And all these interventions which we have planned directly or indirectly contribute towards impacting those indicators. Just to give you an idea about what is our overall program, it's an investment of about $120 million over this period of time, and it's across about 7 or 8 partners who will work with us. We've listed out the names. So the Integrated Family Health Initiative is being driven by CARE, who's among the largest partners on this program. The infectious diseases piece is managed through WHP, World Health Partners. Similarly, we have PSI. The payments piece, which I was talking to you about, is being managed through IFC, the International Finance Corporation. BBC helps work a lot, and I will share that with you on some of the good practices and the job aids which we have created as part of this program. PCI is doing extensive work and very good work on community mobilization and social accountability, because there is a very large non-technology part which is at play on the ground, which actually helps change behavior as well. Technology is just one of those enablers. And we have CARE also looking at the Kala Azar elimination project. So overall, we have a fair bit of integrated methods of working on this program, both on the demand side and the supply side. And it's been working very, very effectively so far. Moving on to slide number 8. Okay, the animation was supposed to bring out the ICT interventions little more differently, but the way it's described here, let me just run you past that. So we believe that to improve the health outcomes, you have to work on both sides, the side of shaping the demand and enabling the practices, and the other side of improving the supply. So you have to work on the beneficiary and behavior change on one side, and you have to work on the health enablers, whether it is the facilities, or whether it's the frontline workers, whether it is the supply of drugs and equipment. So those are the supply side. So we've just highlighted some of the areas where we have specifically undertaken initiatives, the ones that you see on pink, which are important from an mHealth perspective. So we have a couple of solutions, and I will talk a little more about it as we go along the next couple of slides, called Mobile Kunji and Mobile Academy. These are very interesting solutions which have been co-developed along with BBC Media Action, which is the BBC's social services arm, who have worked extensively in Bihar to work on these solutions, and these solutions have had great national level acceptance, to the extent that now the central government has actually said that we want to roll these out nationally in India. So there's been a great thrust of these solutions and actual improvement on the ground in terms of communication on the demand side. On the supply side, the frontline workers through the system of continuum of care, which also I will talk about a little more, where they are able to strengthen data management, ensure that they track beneficiaries more effectively, and we are able to deliver services, is the other great solution which we have put on the ground. The payments piece, which I mentioned to you, is something which we are working on right now with the IFC. So there are and mobile training, skill labs, and so on and so forth. So there are various ICT interventions programs which are running very specifically in Bihar. The term which you see used, Ananya, is actually the name of our program. It's a Hindi word which means unique. So the Bihar program is called Ananya. Moving on to slide number 9. I'll briefly talk about some of these initiatives which have been taken on the mHealth, eHealth side. So BBC, which is our partner in Bihar, a key partner in Bihar, has been focused on building the awareness, influencing attitudes, improving beneficiaries' health behaviors significantly among pregnant women and mothers of children who are up to 2 years old. We call it our -9 to 2 year program. So from the time a mother is considered to be expecting till the time a child turns 2 years old, we work towards this entire continuum of care, as we call it. So 3 key initiatives which BBC is running along with the foundation. Number 1 is a mobile academy. Now this is an IVR-based training course. We understood that the frontline workers also need to be trained. They also need to be upskilled on a continuous basis, because their knowledge also needs to be replenished and refreshed. And as a result, we ensured that we have a significant number of people in the frontline worker community who are part of this Mobile Academy program. They are able to learn more about preventive health education, which in turn they are able to more effectively pass on to the beneficiaries. So at last count, we had about 36,000 unique frontline workers. They pay about 50 paisa per minute, which is a very, very small amount if you convert it in whichever currency, and they get about 5.1 million minutes of health education content, these 36,000 frontline workers. Of them, about 17,500, almost 50%, have already completed, it's actually 45%, have actually completed the course. So in a way, we also certify them. So it's also a great achievement for them that they have got certified, and we also believe that this is done. So the question I believe somebody's asking is, how is it delivered? This is delivered more in form of an IVR-based training course. So it's a call-based course. The IVR systems are set up in such a way that you can run through a program to a certain module. If you disconnect the IVR in the middle, it restarts from the place where you left it last time. So there's continuity of the course as you go along. And we've seen that this is added, and obviously this course is made and designed in a language which is more localized. They understand it very well and they're able to appreciate it. So it's not an English-based course where they have a tough time comprehending it. So the health workers listen to this. They listen into the course. There are various questions which are also asked, and they have to punch in their answers as they go along. So it's in a way like a CBT, which is enabled through an IVR-based device, and that really helps them to sort of learn better and learn in a very, very innovative way as they go along. The Mobile Kunji, which is the other very, very successful initiative, is actually a combination of a technology-based tool as well as a manual tool. And we showed it to Alvin and Bunchai over there on how it works. So there is a unique shortcode which allows, so the mobile phone which is carried by the frontline worker has a unique shortcode which allows the frontline worker to play health audio content to the frontline, to the beneficiary they're sitting with. So they might be sitting with an expecting mother, and they need to give her a view on what are the good practices in breastfeeding, or for maintaining the better nutrition of the child, or for better sanitation. So they can play an audio through that device. And these audios are, like I said earlier, so customized, and they're so customized to the local dialect that the language is very easy to comprehend. There is a story built around it, and the story mode is audible to the beneficiary, and they tend to sort of understand and react to it very, very positively. So we've had very good success in this area. We've got 132,000 unique users right now, listening to about 4.2 million minutes of content, and that's 400,000 minutes per month. So significantly improve the messaging, significantly improve elements of behavior change which we are noticing in the people there. The third service is a service called Kilkari, and that's a subscription-based service and at a very, very nominal cost. So each family will subscribe, each family in that area can subscribe to Kilkari. They receive weekly calls in a recorded message from a doctor, a female doctor, and mind you, that's an important thing here at times in the rural areas, who will communicate very relevant, sensitive messages to the mother depending on what stage of pregnancy she is. So this will be an IVR-based callback mechanism. It's given at a very nominal fee, and it will give them the content, the guidance on what are the various methods of safe delivery, how to take newborn care better, how do you ensure that you should take immunization for yourself and for the child who's going to be born, and other messages. So key health messages are given to them on a subscription basis, and it's been used up very effectively. We also have a follow-up mechanism which we support. We have a call center as well which we run, because to push the demand, sometimes you also need to push it through a little harder through actual calls. So we actually call some of these beneficiaries and say, hey, have you used this service? Have you seen benefit? If not, why don't you look at it, and so on and so forth. So there's a fair bit of interactive exercise which needs to happen with the beneficiaries to enable that behavior change. So MOTECH is at the center of driving these three key initiatives, and it has emerged as a very, very strong tool for us to have these mobile-based training and capacity building programs, not just in Bihar, but across the world. And now we have, like I said earlier, the government has given us a clear mandate that, why don't we sort of take it across? And I think 6 or 7 states have already signed up besides Bihar and UP. So there is fair bit of traction which this particular sets of solutions are getting in the mobile health sector in India right now. Let me move on, and I'll also just keep a time check on our presentation. And thanks, Jay, for all the inputs and tips which you're giving everybody, and especially describing some of the colloquial Hindi words. On slide 10, I've talked a bit about the care solution. Now, this is the solution which I was mentioning earlier, that how do we ensure that from beneficiary registration up till service delivery, we are able to, in a way, automate the process and have far better data collected and ensure that the beneficiaries are getting more timely health interventions. So we designed this program called Continuum of Care. This was started in late 2012, so it's been in operation for about 18 months right now. Like I said, it impacts about 1.3 million people in that particular community, which is about 4 blocks of Bihar in one district, and about 500 frontline workers use it. Now you would also notice the term AWW here besides the ASHA. AWW is another frontline worker who's not necessarily a Department of Health worker, but comes from the Department of Social Welfare. Now that's a department which looks after nutrition in India. So in India, health and nutrition are in a way segregated between Ministry of Health and Department of Social Welfare. So both of them have a role to play. Now the key thing about this program, besides talking about the technology intervention, is that in my opinion, for the first time in India, you've had 2 sets of frontline workers actually work in a very cohesive manner towards delivering a service. Because if you really look at it, both their services have a very similar impact to the end beneficiary. For example, while the ASHA facilitates the pregnancy, the immunization, the post-birth related immunization for the child, and so on and so forth, the AWW, which is the Anganwadi, is responsible for the nutrition of the child. So in a way, both of them have a very strong role to play together in terms of driving a certain change in behavior and ensuring things happen on the ground from a healthcare perspective, because nutrition at the end of the day impacts health. So in this program, we have given handheld mobile devices to about 500 ASHAs and Anganwadis with an application loaded on it called the CCS, which is the Continuum of Care application. Now this application allows them to do a few things. To start with, the entire process of registration of an expecting mother or a child post-birth is all now available on that application. Now based on that registration, they have a complete scheduler of that mother available to them on their mobile phone. So from the moment you enter the date of the last menstrual period, it automatically allows you to calculate the expected date of delivery. And in that 9-month period, whatever are the specific interventions required from an immunization perspective, from a nutrition perspective, are all enabled in the application, including things like what kind of tablets need to be, whether iron, zinc tablets need to be prescribed and given. So the entire care period within that 9 months, and post that 9 months, once a delivery happens, that data also goes into this application. And beyond that, the entire child care method will be able to track for 24 months how the child needs to be immunized and managed. So essentially, this application, like the name describes, allows us to cover the entire -9 to 24-month period. This is a very important piece of technology which is implemented there, because it cuts down on many of those challenges which we've had in the past, which is essentially to do with data capture. It goes beyond data capture for compliance purposes. It actually looks at data capture to plan healthcare interventions. And for us, a key objective is how this system will ultimately integrate with the government system and they would have all that data and access to information which they need to plan very specific health outcomes. So we believe that this has already shown many good results, the early signs. We are doing a far more detailed analysis as we will complete almost 2 years of its implementation in the next couple of months. We have already seen that the home visits of the frontline workers have increased from 54% to 87%. So even the frontline workers, because now they have this device on their hand, feel far more confident. Even it's a matter of pride for them to go and visit and capture information from the beneficiaries in a more structured manner. The pregnant women visits who were visited has increased from 65% to 85%. Actually, there's some typo there. My apologies for that. So there have been initial results which we have seen, which are giving us encouraging signs that we are seeing some benefits of this. And how do we scale up, ramp up, take it to the next level, integrate with the government systems are our next strategic answers which we are going to ask for ourselves and make sure that this happens in the time to come. So CARE has worked very effectively with us, has been a great partner with us in driving this program. Moving on. The other important partner for us has been the World Health Partner, who have been largely focusing on a high quality program for TB management, which includes the complete diagnosis and treatment for the rural population. So we work effectively with WHP. MOTECH, the WHP has a MOTECH version which works for them. They manage it through a central medical facility. They have labs and various shops through which they distribute the associated medicines, and they have what we call a Sky Health Center. And these are centers which in a way help you have a telemedicine kind of a setup where they have a remote doctor providing advice in the village, and these are set up in many villages in Bihar, and they are managed by the WHP folks, and they run the backend application using the MOTECH platform. So there's been significant efforts on the TB side as well using MOTECH, and I'll talk about the other program which we are just starting on the TB side in the subsequent slides as well. Moving on to slide number 12, or it's right there, the next one. Oh, okay. Again, I think the animation has beeped out the content behind the front slide. So the TB control program in India has been very key to the government because we've had challenges in ensuring adherence and compliance with TB treatment. And as many of you would be aware, that controlling TB is largely got to do with ensuring compliance on a continuous basis of a treatment plan. And if there's any deviation to that treatment plan, we have cases where it can relapse, and in some really tough cases, it can get into a situation of being a multi-drug resistant or totally drug resistant, which are very serious cases. So there is a current program in the government wherein some bit of tracking is done of suspects and of potential patients of TB. However, it's limited to the public sector, and it doesn't have actually any interface to the private sector. And today, many of the cases of TB are actually going into the private sector as well. So our intent was to have a larger program which is built in, which will ensure that you are able to track right from suspects, ensure that they go to an accredited health provider because everybody cannot give you the correct advice on tuberculosis. Based on that, you go to the right diagnostic center for the right kind of test, because today again multiple tests are done which may or may not be the most appropriate ones for diagnosing TB. Then you go to a government nominated pharmacist who will give you the medicines which are associated, because the medicines are given for free by the government of India. And then you have the complete treatment adherence plan. So in a way, that's the life cycle of the overall TB program, and ICT will play a huge role in enabling some of this tracking. So that project has just started off, and again MOTECH is going to be at the core of developing the solution, and we hope to see hopefully very positive results of this solution and enabling us to have better management, diagnostic and tracking of TB suspects. So this is a key program for us, and we believe that MOTECH will play a key part in enabling TB control in India. Moving on to slide number 13. Just wanted to share with you a broad high-level architecture and design of how the various MOTECH modules and the M services ecosystem work. And we've used India as an example here because most of the solutions that I've quoted to you are India-based solutions. So we have the various modules which are running on the MOTECH platform, and these are across the various service providers. So BBC is running content and training of that. We have Digital Green, which is running a content on that. We have other providers who are running content on that, and that the module actually helps us integrate the various types of content together: the video, text, voice-based content. Within that, we have accessibility to the various messaging platforms which MOTECH enables, whether it's voice, text, or data. To support that, we have built in the relevant reporting mechanisms, and the data stores are getting integrated. And not all the data stores, like I mentioned earlier, are integrated, but they would get integrated at some point in time. And finally, the link to the government system, where you see in red, it says to MCPS, to Aadhaar, to NICSHARE. I think that's the key link for us. We will have to enable these platforms in such a way that it will drive data, it will drive information onto the government systems as well. So that at a broad level is the overall MOTECH ecosystem at this point in time, and it's evolving as we go along. Moving on to slide 14, which is essentially the various individual systems. So I can skip this, as I've already talked about the individual systems, and also the slide will not be very viewable. So just a quick timeline, and if Tim, if you're on the call, it would be nice to get your view as well, because you've been part of this timeline as well.
Yep, I'm still on the line.
So yeah, so the involvement of the Grameen Foundation was a key for us in initiating our efforts in MOTECH, which started way back earlier in 2008-2009, and the focus at that point in time was initially to start a mobile health platform for serving pregnant women and Ghanaian frontline workers, and it was at that point in time branded MOTECH. And subsequently, we've had various partners who come forward and work with us extensively. The funds were granted to CARE, WHP, BBC in India and Bihar, and like I mentioned, there was collaborative development with Grameen, Dimagi, and many others to scale up MOTECH. And some of these are not necessarily only BMGF funded initiatives. There are other initiatives like what Johnson & Johnson is doing, which they're using the MOTECH platform for adherence on HIV. That's not funded by us, but the platform is used by them. And similarly, World Vision is using this platform starting a year or so ago, where they're building MOTECH interfaces into supply chain and payment systems. So there has been an evolution of MOTECH both within foundation-funded projects and external events which are there. And we have seen that now its usage has significantly grown over the years. And within India per se, we are looking at how do we scale it up within Bihar, within our states of focus, as well as other states, and the integration possibilities. So there are definitely a lot of exciting times ahead on MOTECH and the way it's getting evolved as we go along. So my last slide is obviously implementing any solution, and many of you who are familiar with the way the government works and the systems work on the ground have its share of challenges. And I have worked extensively not just in healthcare but across multiple sectors like urban, rural development, police modernization, and immigration, where we've had government support as a key part towards ensuring that the ICT interventions get delivered. Because ultimately the service delivery responsibility rests with them. So that is for us very essential, and therefore the integration with their systems also becomes equally essential. The other thing which we realized, and we in a way knew it, but we always wanted to keep a close view of it, is that the technology only serves as an overlay to what the beneficiaries and the workers need to do. There are a whole lot of things which they need to do in any case. We are just helping them be aware of what is it that technology can do for them. And it is not to add to their burden. So we have been very conscious of the fact that any technology which we implement doesn't necessarily add to burden, but helps bring about more efficiencies with the least amount of additional effort. And in case of mobile technology, the good part always has been that there's been a fair bit of familiarity with mobiles, even though largely it was for call making, and in rural India very rarely even for SMS. But at least when I went, and I go very often, and I see the workers on the ground, many of them are not educated but still are able to comprehend the solution. I think mobile has that thing which allows you to do that. Moving on, change management, cliched, but it can't be more stressed than before. Absolutely essential to help getting this done. And I personally believe that you can give a mobile device with an application to a frontline worker, but there's so many other things you need to do around it to help them use it and actually adopt it favorably. And that's the great effort which our care team and our teams in Bihar put in. The amount of time they spend on training, the amount of time they spend on getting them to get familiar is absolutely mind-boggling. So there is great importance of driving change through other means, even when implementing technology. And I mentioned the technology is just a smaller part of the intervention. And finally, targeting the right services for the right beneficiaries is essential. There can be a tendency to do too much and not prioritize. So, for example, when we look at diagnostics, today there are devices which can do hundreds of diagnostics for you on a tablet. But the fact of the matter is, do we need all those diagnostics? What are our critical diagnostics? What are the ones that make the maximum impact to health indicators? So our focus is on that. So if we feel that measuring BP, measuring anemia are two important points for us to reduce high-risk pregnancies, our focus is more on that right now. I may also need a diagnostic later to detect a bipolar disorder, but is that a priority right now? May not be. So therefore, it's very important to have the right service at the right beneficiary at the right time, so that you're able to focus on the specific health indicators which you're working on. And that's how we've always had this very strong technology and on-the-ground view of things in Bihar and elsewhere, so that we are implementing the right things at the right time. So that's, in a way, that's the summary from my end of this presentation. I'm very happy to take any views, any notes from anyone.
Thank you so much, Rahul, for that very detailed presentation about MOTECH. If our listeners and our participants could stay for some 5 minutes for a quick question and answer portion. I'm now introducing you to Jay Ganesh, our AeHIN Working Council from India, who could handle our discussion for this afternoon. Hi, Jay. Are you there, Jay? You have a mic with you. For your questions, you can chat it in our chat box right now. So I have this to start the ball rolling. I have a question. MOTECH is more than studying the system and workflow, but it's about delivering content useful for the situation of pregnant women and healthcare providers. What were the challenges you faced in establishing this kind of system within India?
That's a good question. Obviously, putting a technology-based solution in the most rural part of India, where you have 89% of the population as rural population in Bihar, was not the easiest of things. And if you also see it, we did not bring in the technology the moment we started the program. So the program was started sometime in 2010 mid, and the technology intervention started coming in a year or so later. So we had to really understand the situation on the ground, understand what is the level of potential acceptance of technology, and also see where that usage will clearly impact. So when I said the right services for the right beneficiaries. Now, once we had the technology implemented, we still had a few challenges. I'll give you one of the challenges, which is something we have to address. Tech support, for example, is not the easiest, right? For all of us on this call, we have a problem with our laptops and we call our respective organization tech support. We can get it on the phone and are reasonably conversant with technology to solve it ourselves. But if the frontline worker's phone conks off or a certain app doesn't work, you can't offer her, necessarily a phone-based support. You can't really tell her do this, do that, and so on and so forth. So tech support is important, and for that we have to have people on the ground who would be available, and also to ensure that we have least amount of problems with those devices and those applications. So there have been challenges definitely on the ground, but so far we've been able to overcome them or have ways to manage them so that it does not impact the end objective of that program.
Thanks on that. Hello, Jay. Go ahead.
Yeah, Rahul, this is Jay here. It was nice. Yeah, Rahul. I just have a question. I've seen the chat box queries that is coming from the participants. One of the things that is coming up is regarding what exactly the MOTECH is, whether it is available for download and whether it is available for free and without any user license, and what kind of scenarios it will work. Is there any ready-made use cases that is available? Because I have seen some of the queries that is coming up in the chat window. If you can probably brief that on that.
Right. So I'll give a brief on that and probably also ask him to add on to that in terms of licensing and usage. It's an open source based platform. It is available for download off motechsuite.org. Very specifically, which are the use cases? Maybe Tim, you have a view on that, which are available for them to see.
Okay. And what kind of skills are required for implementation teams? Because that is another query that has come up. How easy or how difficult it is to implement, and what kind of basic skill sets that you are looking at? Do you need to have a programmers in the team?
Right. So the MOTECH platform is extremely well modularized. So you can set up rules, you can design your app very, very effectively on that platform. It also is integrated with some of the other platforms. For example, in CCS, we have ComCare, which is the other platform which is running there. And therefore, you are able to integrate it very well. So you don't necessarily require significant programming capabilities to do that, because the platform has built-in capabilities to a large extent.
Okay.
I think there was another question that how much training is needed for frontline health workers. Very important question, and
yes,
I can tell you that without training, the solution will just not work, because we have spent hours and hours in getting them trained. We have, more importantly, the training is not just from a technology perspective that how to use. It's about also how it will make an impact. So their ability to have that conversation with the beneficiary is also as important as their ability to enter data into the phone. Because the change we are really looking at is that the time spent with the beneficiary is more fruitful, and a byproduct of that is that you capture a lot of that information ready-made online onto a device. So it's not, the objective is not go out and do data capture. The objective is have a meaningful conversation and use this device as an enabler for that meaningful conversation. So that's how the training has to be done.
Okay. Thanks, Rahul. If another question that probably that will be there in every participant's mind in this webinar is if somebody wants in the group wants to implement MOTECH now, what's the procedure? I mean, is there any particular approach they should approach you, or how is it?
Yeah, so you please feel free to get in touch with me, and I will be happy to guide you in that regard.
Okay.
I think there was another very important question. I think it got missed out from Sushil. And Sushil, this is a very important question we asked. Is there evidence of health outcome? Whether antenatal compliance, institutional deliveries, reduced complications. We have definitely seen improved health outcomes. We are now trying to see how much of that improvement is very specific to the technology application which we have deployed, and or is it a combination of other factors or actual on the ground work on effective behavior change communication and other initiatives? Because the program runs as an overall program. Technology is one part of it. So what we're doing is in the month of June, July, we are having a random controlled trial. We're having the end line of that. We've actually done the initial baseline, done the midline for the CCS solution. So we will have an end line in June, July, probably August time frame as we complete 2 years. And there we will be very specifically be able to see if the outcomes have had a very significant impact because of the deployment of the mobile-based solution. So what's the space for that? And that's an important question, and that's a question which we in the foundation are as eager to know as anybody else would be.
Okay, that's great.
Right. Is there any questions that I've missed out? Let me just quickly scroll back. Okay, there's a question. Is there any government involvement for incentives with health workers? Oh, absolutely. The incentives are actually paid by the government. It's just the mechanism of payment which is where we have the challenges. And that's why we are looking at having the MOTECH-based HOPE solution in place for ensuring that those incentives come out quickly.
Okay, thank you so much for this afternoon session. We really appreciate all the inputs that you have provided and for sharing MOTECH with us. Can we share your presentation with the rest of the people who attended this session?
Sure, Ali, I will send you a version. You can share that. No issues whatsoever.
Yes, okay. Thank you so much. If we just have time, we can have a short photo taking session. Please open your webcam so that we could capture your virtual presence in this AeHIN Hour. And also, please stand by for my email for the evaluation of the session so that I can, and upon receiving your evaluation, I will be able to send you your copy of the slides for this afternoon. So if you're ready, please open your webcam so that we could take a headshot of everyone who attended this meeting room. Thank you so much for the countries who attended here, most especially from those in the ministries of health. Okay, so I will take the headshot of our first batch of participants I have here. Okay, while waiting, I would like to thank our friends from the Ministry of Sri Lanka, Indonesia, and technical officers from GIZ Bangladesh. So I'm taking the photo now for Jay, John, Jude Tayaban Kosala from Sri Lanka, and Muhammad Ula from Bangladesh. Smile, 1, 2, 3. There, I got it. So thank you so much. You could turn off your video. I will go now for Rahul, for Ramesh, for Celia from Cambodia, from Sushil from Nepal, and Winmit. Smile, 1, 2, 3. Thank you so much. And for the last two batch, I hope their webcam are on. For those who I've taken their photo, you could now turn off your video cam. So I think we're on. Thank you so much for being with us this afternoon. See you April. Thank you so much, Tim. Thank you so much, John. And thank you so much, Rahul and Jay, for handling this session. See you April 25 for another session of our AeHIN Hour on National eHealth Strategies with Peter Drury, where we will learn more about National eHealth Strategies and how to implement it. For the April 25 session, we will be giving out certificate of attendance for those who will attend a series of our AeHIN hours on the National eHealth Strategy. Thank you so much. See you next AeHIN hour. Thank you.